Extend a very warm welcome to all the delegates, faculty members, organizers, and the whole IRA family from the south, including people from the north also, who were willing to participate as delegates. And on behalf of the organizing committee, my peers and my junior colleagues who have undertaken a Herculean task of organizing this program, I extend a very warm welcome once again. And without further delay, I think we'll go ahead with the proceedings. We thank all the speakers and the chairpersons who have set aside their valuable time and have come here all the way. Enjoy yourselves, have a wonderful academic feast, and go back happy and in a lovely mode. Thank you, and we'll go ahead with the proceedings, and we'll start the first session from now on. Thank you, one and all.
Good morning, one and all. Today's scientific program has been divided into 4 topics: spondyloarthritis, interstitial lung disease, resistant and refractory disease, along with that translating evidence into clinical practice. To start with, we start with spondyloarthritis. So the first speaker of today is Dr. Vinod Ravindran. I request sir to be on stage, please. And the chairpersons for the event are Dr. V. Krishnamurthy and Dr. Gladstone Chelaya. So where does the road lead to? The evolution of AS is non-radiographic SPA, always a forerunner. This is the topic which kicks away the day today.
Okay, and this is the first slide. Next slide. All right. Once it's open. Cindy.
It is a great pleasure to introduce Dr. Ravindran, who needs little introduction. As you can see from the photograph, he was trained in United Kingdom, and he has been an editor of Indian Journal of Rheumatology for some time, and now he is the editor-in-chief Journal of Royal College of Edinburgh. He has held quite a lot of important positions in Indian rheumatology, and I know him for a long time during his time in United Kingdom. And it is a great pleasure to welcome Dr. Vinod Ravindran. Thank you.
Yeah. Thank you, Chase. Good morning. And to start with, really heartfelt thanks to Dr. V. Krishnamurthy sir and Rajeshwari ma'am for this kind invitation. Yesterday there was a workshop on MRI in spondyloarthritis, and I hope that those faculty are not here in the hall. Okay, and welcome, greetings from Calicut, Kerala, to all my friends here. So the topic is basically non-radiographic axial spondyloarthritis, very long, complicated, sort of tongue-twisting, entity. So the spondyloarthritis leads to complete immobility of the spine by causing extensive fusion is well known. This is nearly 2000 BC. I mean, that is nearly 4,500-year-old mummy. And what can be seen here is the neck of the mummy was broken before it was put into the sarcophagus, so that the mummy can actually lie flat. Because this mummy's spine, as revealed by the MRI, was completely fused due to ankylosing spondylitis. And this is also sort of well known, and this is sort of a more recent type of literature you can see. Now, the topic I would be discussing is what is the natural history of this entity? And are there any risk factors for progression in the radiographs from the non-radiographic stage to the full-blown ankylosing spondylitis? And the question which is still unanswered, by and large, that whether this entity represents an earlier stage of the same disease process. Okay. So when we look at the X-rays of the SI joints, we all know that grade 0 is normal and the grade 4 is total ankylosis. And these are the grades which are actually very clear to be commented upon in our routine clinical practice. But grade 2, 1, and 3, they are actually quite difficult. But when you consider the modified New York criteria, these are actually the basis for somebody to be classified as spondyloarthritis. The problem with the radiographs, as we all know, is that it's difficult for these in-between gradings to be rightly sort of, labeled as such, and they are by and large not reproducible. There are inconsistencies among different radiographers reading them, whether they are, locally based or whether they are blinded or remotely based. In the radiographs, the various type of things can be seen related to the disease process of spondyloarthritis. It could be inflammatory, where as the most important things, it can be picked up by the MRI scene, that is the bone marrow edema. But in the later stages of the diseases, you see osteoproliferative lesions, which are syndesmophytes. So the impetus for the reclassification or a relook at the classification of spondyloarthritis came about with the knowledge that the spondyloarthritis or spondylitis process can be there even without the presence of sacroiliitis as seen on the X-ray. And this was the basis why the newer criteria come up with the term that is called non-radiographic axial spondyloarthritis. And this is basically that. So the non-radiographic stage is basically what's the stage we are most interested in. The patient has got a lot of features of the SPA, but the sacroiliitis can only be demonstrated on the MRI, not on the plain X-ray. But as the disease progresses, you have other changes, including syndesmophytosis, and the radiographically it is evident. And if you are using the older classification criteria, it can be correctly labeled at that stage as ankylosing spondylitis. Whereas in the newer criteria, you all know, there is an imaging arm and there is a clinical arm. And patients who are on this arm, they all are actually non-radiographic spondyloarthritis because you are not actually doing the MRI here. Now, the problem the need for the modified criteria was that the radiographic criteria based on the modification of the New York criteria was not found to be sufficiently sensitive. When the anti-TNF agent came about, there was a felt need for expanding the indication to cover this group of patients who do not have changes on their radiographs. That was the second need. MRI as an investigation of choice to pick up the early lesions in spondyloarthritis was also well recognized at that time. So these three were the reasons why it was felt that a change in the modified in the existing criteria is required. And it is indeed driven by a desire, like in rheumatoid arthritis, to pick up the patients very early in their disease process, so that if there are any interventions which can actually stop the progression from the earlier stage to the full-blown condition, can be utilized. In the newer criteria, the key thing on the MRI, as I'm sure would have been discussed yesterday, is actually the presence of bone marrow edema. And these are the MRI criteria for the axial SPA in the ASAS card criteria. That's the presence of either one bone marrow edema lesion on 2 consecutive MRI slices or more than 2 or 2 or more lesions on the single slide. And this is basically for trained radiologists and people, and rheumatologists who are trained in looking at these type of MRI. This type of full-blown, very, very dramatic type of bone marrow edema is also seen. But people who have non-radiographic axial spondyloarthritis, they are likely to have lower CRP, lower lower number of these type of lesions, so that you may not see the full-blown bone marrow edema, but it will be very subtle. So that's why you can see that the very sort of specific MRI criteria was actually proposed. These patients are usually females, low body weight. The specificity of MRI was also questioned, because there are 2 or 3 interesting studies, and I'll go through in sequence. So there are a lot of studies came about from 2010 till this time, or 2005 till this time, where low-grade bone marrow edema was found in 1/4 of healthy individuals. And these patients, if you look very, very carefully, may have up to 4 clinical criteria of spondyloarthritis, but they will not fulfill the criteria. Then there was a large study where more than 1,000 patients in the young age group who had persistent low back pain of any nature had MRI, and 217 patients, 21% had sacroiliitis on MRI according to the ASAS criteria. But these patients did not have spondyloarthritis, and they did not even have non-radiographic spondyloarthritis if we use the full classification criteria. So what is happening to these individuals? They have low back pain, and they have changes on the MRI, but they don't have the disease. So this type of scenario all of us face in any type of disease we come across. Then this study, what they did was 20 young runners and about 21 ice hockey players. They did their MRI, so they are free of disease. They don't have any symptoms at all. So yeah, they are actually young adult athletes. So before the session of running and after the session of running, and for the ice hockey players during a very active season, they had MRI, and you can see that in these young, healthy adult individuals, bone marrow edema was actually present. And it was present in the higher numbers required than the ASAS criteria for them to be diagnosed as spondyloarthritis. But again, these are young people. They are free of the disease. So I think these are the few reasons why basing the diagnosis solely on the MRI and labeling them as non-radiographic spondyloarthritis, whereas MRI's sensitivity itself is questionable, is another sort of school of thought which is developing. When you look at the treatment aspect, this is, by the way, is called Hippocrates table, where in olden days the table was used to create artificial fractures of the spine as a treatment for ankylosing spondylitis. But now we have lot of agents, including the anti-TNF agents. And these are the trials where the anti-TNF agents have been specifically used in the non-radiographic axial SPA. And it does work. So you got everything. You got adalimumab, you got golimumab, and you got infliximab. So all the maps are there, and they do work. So all the anti-TNF agents, they do work. But the infliximab was not actually, sorry about that, the infliximab was not actually tested in the axial, non-radiographic axial SPA. So it is not still sort of, an approved indication for that medication in Europe. In US, there was another problem. In US, the application for the anti-TNF agents to be used in non-radiographic axial SPA was actually rejected, because what the FDA said that the specificity of these criteria, including based on the fact the MRI sort of related problems, as I have highlighted, is still unresolved, and then the natural history of this entity is still not clear. So in US, still for the indication of non-radiographic SPA, these medications are actually off-label indications. So 2 or 3 studies looked at the natural history of the non-radiographic SPA. One was this study, which was from the Netherlands. And you can see that the more than 300 patients of a mean age of 34, only 16% progressed to the full, the radiographic SPA criteria in 2 years. Okay, so a very small number. And then predictors for this progression was bone marrow edema, longer symptom duration, and age. I mean, you know that patients who are progressing with high disease burden, if they are left like that, they are bound to develop syndesmophyte. So in all the studies, you can see the longer symptom duration is one of the predictors. More bone marrow edema means more disease activity. That is also a proven indicator for the progression. Then this study was from US, and you can see that 28% of the 120 patients progressed diagnosed with non-radiographic SPA. So just about 1/4 of the patients progressed to the radiographic stage in over the 10+ years time. So this is a very, very slow type of progression. And again, you can see the predictors where the inflammatory changes on the MRI. So the more inflammatory changes, more is going to be the damage. And additionally, they found the presence of HLA-B27 and smoking. This German cohort, you can still sort of, see the same signals coming out. If they have, there is no difference between the 2 groups, but you can see that the disease scores between the 2 groups actually was not remarkably different. When it comes to diagnosis, we are all very much focused on diagnosis, and rightly so. The problem, as has been highlighted many times, that the diagnostic criteria are mainly used to establish a diagnosis to guide the individual patient's care, whereas classification criteria, as you all know, is to allow uniform recruitment of patients into the clinical trial. So in reality, even though, we may use the classification criteria as different items, just 1 minute, to label somebody as having the disease, but they are actually not meant to be used in that manner. So on clinical grounds alone, you will be able to justify the diagnosis such made of the spondyloarthritis patients. And this is a useful, I always find this is a useful sort of mnemonic in your clinical practice to remind ourselves about some of the other features of SPA. In this study, the point of these 2 studies was that, it does not really make a difference So people who were reclassified or relabeled as non-radiographic axial SPA already had diagnosis of ankylosing spondylitis made and were being treated for that condition. And here the classification criteria was not used. So many of us keep treating the patients based on our clinical sort of, overall judgment rather than sort of, using the classification criteria. But it is important that, a difference between the early and the late stages are made on the clinical grounds, taking particular note of the disease duration, because that has got the most important bearing. And this, I must show, this is a very good study published from NIMS, Meghna and colleagues. And as a final slide, writing an editorial based on this good study, we picked up 3 unique features which are peculiar to India when it comes to non-radiographic spondyloarthritis. One is the poor recognition of inflammatory back pain and diagnostic delay. And we propose that education is the most important thing about this condition. Then issues related to MRI. Yesterday's MRI workshop was also, I think, a right step in this direction, where we emphasize on choosing wisely and then actually educating the wiser use of this investigation. And we really don't know whether our patients are any different from what is published in the Western literature. So this is, I think, important for our colleagues to look into in a proper manner. Thank you. I'm sorry for exceeding my time.
Okay. We'll have 1 or 2 questions. Yeah, Narsimulu. Take the microphone.
2016 publication mentioned 25% of the 1,026 patients who have backache had MRI evidence of sacroiliac arthritis. Right? How many has Patrick's positive? How many has Patrick's negative? Any mention the article?
How many?
Patrick's positive and negative. Backache with Patrick positive, yield will more. Backache with Patrick negative, yield more. Any mention on that?
So meaning the patients who had back pain and had positive MRI. So all the patients had back pain, and that many patients had positive MRI.
Backache, inflammatory backache, Patrick's and non-inflammatory backache.
Yeah.
Inflammatory backache, Patrick positive, Patrick negative, like that.
I think he's asking about the SIJ stress test, isn't it?
Yeah. But MRI evidence of sacroiliac arthritis there. So inflammatory sacroiliac arthritis, Patrick positive, non-inflammatory it is negative.
Okay.
See, degenerative sacroiliac arthritis, Patrick's will be negative. Whereas inflammatory, it will be positive.
Any other questions?
Is there any mention in the article, detailed discussion?
I had to look up.
Thank you.
Okay. Any other question, please? Okay. Thank you, Vinod, for having kick-started the program. Thank you very much. Thank you. We go on to the next program, is it? I thank co-chair Gladstone, who has come all the way from UK, my good friend. Thank you.
Thank you so much, sir. So the chairpersons for the next session are Dr. V. Krishnamurthy and Dr. Dharmanand. The topic is Predictors of Psoriatic Arthritis, to be delivered by Dr. Carlos Semi.
I have the pleasure of introducing you to Professor Carlos from Italy, and Salmi is a very well-known face in the Indian scenario, and is a good orator, and he loves to come to India. We all share something like the Mediterranean weather there as well as the South Indian weather is almost similar, hot and humid. They all take a siesta, which is common with us also. We also sleep in the afternoon. Only thing is we have pot bellies they don't have. So today he'll talk to us about inflammatory arthritis, inhalation and the markers after him. Thank you, sir. Welcome, sir.
Well, thank you, Mr. Chairman. It's a true pleasure to be here, and I'm sure you, for those of you who have already met me, you know that I truly love coming here every time. So today I had a very wide title, as you have seen in the program. So, predictors of inflammatory arthritis. I could have been talking about anything I wanted, basically. So, my final choice, and I hope this will not disappoint you too much, was to try and give a parallel overview of psoriatic arthritis and rheumatoid arthritis. So, most of these will be arbitrary choices, if not my opinions. But raise your hands if you're not convinced that treating rheumatoid arthritis is becoming very different from treating psoriatic arthritis today. In my opinion, you are. Okay, we can talk about that. You think it's not, because you think it is. Okay, so you agree with me. Excellent. Because at the end of the day, when you do, in my opinion, when you do a rheumatoid arthritis clinic, meaning all you see is rheumatoid arthritis, rheumatoid arthritis, rheumatoid arthritis, you get out way more relaxed than after doing a psoriatic arthritis clinic. But that's just my opinion, and then again, I'll try to come back to you on that and see if we can agree. Because the unmet needs in rheumatoid arthritis are a long list. We want to treat patients earlier. We want to start the treatment earlier. We want better predictive tools. We need an early diagnosis, new therapeutics, improvement of comorbidity management. In my opinion, we could just change rheumatoid arthritis to psoriatic arthritis, and the wishful thinking would be the very, very same. So these are the 4 points I will touch by, again, trying to go in parallel between rheumatoid and psoriatic arthritis. And the first one is the good news. We're getting so much better at immunophenotyping the diseases. And this reflects, in the case of rheumatoid arthritis, in a much better understanding of the cytokines and the cells involved in the inflammatory and autoimmune cascade, and eventually in the tissue damage. And this is beautifully, we can narrate all this to our patients. You know, in your case, since you're autoantibody positive, I may want to hit B cells, I may want to hit the co-stimulatory mechanisms, and the patient can understand. I mean, immunology is wonderful to be narrated. It's like a novel. In the case of psoriatic, things get a little more complicated because we can use part of what we said before, but the characters change. You know, we are witnessing a major drift in the immunopathogenesis of rheumatoid arthritis compared to psoriatic arthritis. And this is well reflected, for example, and probably for the major part by the IL-17, IL-23 axis. We now have monoclonal antibodies targeting IL-12, IL-23, and IL-17 now with 2 drugs, one already available, one coming up very soon, which are secukinumab and ixekizumab. We have bimekizumab also coming up for IL-17, all of which has shown very limited efficacy in rheumatoid arthritis. And that's, again, something we can tell our patients. You know, we used to use the same drugs used in rheumatoid. Now we can have something more dedicated to your specific condition. And that's something quite surprisingly patients understand very, very well. Even more important, we're getting better from a therapeutic standpoint at shutting down completely one mechanism. Turn on and off. Think of B cell depletion. Think of TNF-alpha inhibition. All that pathway is gone, is blocked by a monoclonal or a soluble receptor. We now have a more accurate way, which in my opinion is working on intracellular signaling, in which you can sort of modulate, acting on JAKs, soon enough we'll be acting on SYK, still acting on intracellular mechanism that may finely tune our immunomodulation. And this is something that probably will soon enough be replaced by something way more complicated, more personalized in the approach to treatment. So how are we doing with drugs? That's probably a little surprising to most of you here, but if we follow the EULA recommendations, which I'm sure, we can choose to follow the ACR, the EULA recommendations. Of course, where I come from, EULA is a little bit more popular. In the case of rheumatoid, we are quite used to start with short-term glucocorticoids, add methotrexate, and if this fails, add a biologic DMARD or a JAK inhibitor. And this is basically a mental flow chart which we're quite used to. Let's see how we do on this. Well, steroids. The recommendations state clearly that it should be a short term. It doesn't say anything compared to the previous version about the dose, but it should be short, should be momentarily used. But in other cases, if we look, rheumatoid arthritis still constitutes the most common indication for chronic glucocorticoid use, more than asthma, more than dermatologists use. Anything is overtaken by rheumatoid. And probably for a sort of self-defense, most of the rheumatologists will say, oh, don't worry, I'm using a low dose, despite the fact that the definition of low dose is nowhere to be found. For some people, it could be 5 milligrams prednisone. For some other, it could be 7.5. Some other could go as high as 10 milligrams of prednisone. However, only 30% of us consider prednisone to be good or excellent. And if we compare it to methotrexate, which is 2/3, or a combination therapy, which is 50%, this is definitely something we can work on. The parallel of the EULA recommendations for rheumatoid arthritis, at least in my opinion, are the GRAPPA recommendations. I must admit I have a conflict of interest. I am part of GRAPPA, so I do think that these are, at least to me, the easiest to follow recommendations. But I'm ready to argue about that. Still, you know, there is no systemic steroid use in the case of psoriatic arthritis, at least according to recommendations. This place, particularly for the axial enthesitis and dactylitis condition, is replaced by NSAIDs. NSAIDs, which should be used in 2 cycles, and if those fails, a DMARD should be added. Are we doing that in real life? Unfortunately, no. These are Italian data. Nearly 50% of patients with psoriatic arthritis are taking non-steroidal anti-inflammatory drugs continuously. That is more than 6 months non-stop every day. And to me, this is very hard to accept, almost unacceptable, I would say. Second step is methotrexate. Oh, we love methotrexate, don't we? We're the only ones loving it because patients really are not too happy when we come up with that, but definitely rheumatologists love that. How are we using it? Well, if we ask the patient, these are very old data. If we ask the patient, would you rather have methotrexate? Would you rather have gold, which you have stopped using for decades now? Would you rather use Arava, leflunomide, or etanercept? The answer is quite surprising. If you don't take money into account, methotrexate is about half liked compared to the gold salts. So patients don't like it, and we have to prescribing methotrexate, at least in my country, takes about 20 minutes because you have to convince the patient it's not chemotherapy. He or she will not lose their hair, will not be nauseous all the time, and that is something quite challenging in daily practice, which also translates in quite poor adherence to the drug. Because if you take the scenario in 24 months, you see that only 43% of patients, as much as 43% of patients will take less than 90% of the prescribed drug. If you take a lower bar, 1/3 of the patients will take 2/3 of the drug you prescribe. That's again something to consider because probably the number one cause for the failure of a treatment is the fact that the patient is not actually taking it at the end of the day. What about psoriatic arthritis? Well, methotrexate has a role, particularly for peripheral arthritis. In some cases, for skin condition can be used. In other cases, perhaps for dactylitis, not really for enthesitis or spondylitis. But still, how do we use it? These are data from the Milan region, from our region, in which we say that methotrexate is taken only by 33% of patients. And more than half of them are taking the oral formulation, which we now know quite well does not have the same bioavailability as the sub-Q or intramuscular formulation. So we're done with the glucocorticoids. We keep using glucocorticoids. We're done with methotrexate. What next? Next is to add on a biologic DMARD according to the current practice. Ooh, that's tricky. What is the current practice? It's habit. The number one driver for any choice of treatment is habit. If you're used to prescribe etanercept, you will continue prescribing etanercept. If you continue to prescribe infliximab, you will go on with that because you feel like you're happy with that. What is the scenario here? The glass is definitely half full. This is ACR 70 across treatments available today. These are not head-to-head, so you cannot compare the response. But the key message here is that about a third to nearly half of the patients treated with anything we have today will get into an ACR 70 response. In the case of psoriatic arthritis, I think we all agree that the ACR response is not really ideal. So I do like to use the minimal disease activity achievement or the DAPSA remission. Consider that MDA does include the skin manifestation while DAPSA does not. And I do like the fact that in real life, no matter what the treatment is, if you use MDA, you get about nearly 50% of patients in minimal disease activity. If you use DAPSA, you're down to a fourth. So we still have a long way to go to make our patients happier. And one of the keys to making patients happier is definitely comorbidities. Because if we look at rheumatoid, depression is definitely the number one comorbidity in our case. We have cardiovascular, we have infectious complications, we have cancer among them, we have gastrointestinal ulcer and COPD, due probably to the smoking association of rheumatoid. If we take PSA, things get even more complicated because depression can be as high as 22%. Anxiety, a third of patients. Cardiovascular disease up to 1 in 10 patients, plus all the metabolic disturbances that do impact our treatment choices. Because if the patient already has a fatty liver disease, probably the available doses of methotrexate will be thinner. We want to be able to go as high as we wished with the dose of methotrexate. Does it matter? Oh, in rheumatoid arthritis, hell it does. Because the more comorbidities you have, the more active your disease will be, regardless of the treatment. So more complicated, more aggressive patients will be responding less to any treatment you choose. How are we working on these? Quite poorly. Because if we look at the patients who have at least one risk yearly evaluation, that's slightly above 50. If we look at patients getting a shot for influenza or pneumococcal infections, it's about less than 20% of patients. So we're not really caring that well. What we're doing better is vitamin D supplementation. We do take better care of the lung. Nearly 90% of patients will be evaluated for the lung regularly. Same thing for antithrombotic therapy if needed. And finally, patient and physician preferences. As I told you, habit is one of the main driver of any drug prescription. But at the end of the day, if we compare TNF inhibitor choices, we know we don't really have superiority data for any of them. The primary determinant of TNF inhibitor among rheumatologists was just physician preference, way more than patient preference or payer guidelines. We like to have our hands free. We like to be free of any type of constraint. But if we ask a patient, and for example, if we ask, would you rather have an oral drug or a subcutaneous drug? Answers are quite surprising. These come from rheumatoid arthritis. 64% of patients prefer an oral treatment. 53% rank the doctor's advice as the most influential factor. And to be most important, patients who had a radiographic damage, those are probably the ones with a more aggressive disease, were less likely to ask for an oral drug. As if patients kind of felt that an oral drug may be less indicated for a more aggressive and more advanced disease. And with this, I'm done. So my conclusions are quite common sense. We still follow a try and error. We have no way of knowing who responds to what the dose need, what's the doses needed, what if other comorbidities. I haven't even mentioned fibromyalgia, but it's obviously in the picture. To me, GRAPPA for PSA and EULA for RA recommendations are preferable, but that depends on the geography. Synthetic drugs remains variable and probably a little overused worldwide. New targeted treatments, and to me, JAK inhibitors and IL-17 are probably the newest kids on the block, which are changing our management of rheumatoid and psoriatic arthritis. Comorbidities are becoming more important. The patients know about it, the physicians know about it, and drive the choices. The good news is that I don't expect that our job will be taken up by artificial intelligence anytime soon, especially for psoriatic arthritis. There's so many variables in there. There's so much medical judgments for which data are not available yet. There will not be a rheumatology app on your phone or on the phone of patients anytime soon. And with this, again, thanks to the organizer for this wonderful and very elegant invitation. And these are the wonderful people I have the privilege to work with in Milan. Thank you very much.
Thank you, Professor Sami, for beautifully bringing out the similarities and dissimilarities in the management of rheumatoid arthritis and psoriatic arthritis. Session is open for questions.
That was eye-opener really, because you conclude by saying trial and error strategies. Whereas right at the beginning, you said you were going to draw a parallel between rheumatoid and psoriatic. Well, if we start from the first point there, you see, when we started off with the DMARDs, we were using them in both. And then perhaps, as you mentioned, and perhaps not, we went on to anti-TNF in both, maybe because of habit or because of the literature. But it's only later on when we discovered that some of these patients who did not respond to DMARDs or to anti-TNF, we started thinking about the different pathogenesis, and that takes you on to your secukinumab. So I think this trial and error strategy is probably because of the changing pathogenesis which we are now learning, which we did not know before. Is that our take-home message, would you say?
That is a fantastic observation. Yes. We know the fingerprint of our patients a little better today. I mean, we're still using probably the wrong glasses to look at the patient, but yes, we do like TNF because in some cases, there's another well-kept secret in rheumatology, and I'm sure you will all agree. Probably some parts, we're not sure that, for example, our seronegative rheumatoid arthritis may not be a psoriatic arthritis at the end of the day, or vice versa, patients with psoriatic arthritis with a cousin with psoriasis and a polyarthritis and no autoantibody may in fact belong better to the galaxy of rheumatoid arthritis instead. So this, plus the fact that we're used to using TNF, makes those the easiest way to go to begin with. But we know that many patients don't respond to that. And in that case, I agree. That's where probably understanding your patient better, ideally with a biomarker. For example, now there's data for which IL-6 levels prior to treatment could predict the response to IL-6 receptor monoclonal antibodies. Particularly there's data on sarilumab, but I'm sure it could be the same on tocilizumab. So that could be one option, and that is probably another drift apart from PSA to rheumatoid for which interleukin-6 targeting is indicated. Another common mechanism could come from JAKs. JAKs are now being used, I'll talk about JAKs later today, but JAKs are currently approved and used for rheumatoid, but they also have very promising data in PSA. So that could be another common trait that we may find down the line. It can't be done today, but it could be another option for a first line. Especially since for JAK inhibitors compared to TNF, we do see, we have no data to support that. No one has gathered the data, but we do see a very rapid response. So if you put treat to target, 3 months, otherwise you change, plus having a faster drug action, you may be able to shorten at least that trial and error approach.
Thank you, Professor Sami.
Can I ask one last question on your, we're talking about this low-dose glucocorticoid. In your practice, do you stop your corticosteroid at 6 months and not carry on at all? Because several physicians do believe that low-dose steroid still has a disease-modifying property. Can you comment on that?
Well, that's another very exciting question for two reasons. Number one, I have no idea whether it's DMARD, because this has been going on for decades to say whether glucocorticoids are disease modifying. They may well be for the bone effects, so they may change some other disease modification. In terms of doses, I generally do all I can to get lower than 5 milligrams a day, because we know in general, besides rheumatoid, that any dosage below prednisone, below 5 milligrams, will not impact the survival of the patient. So if I can get as low as 2.5, I'm not going to fight to get that off real quick. Okay, so that's what I do in practice. I generally start from a medium to low dose, 10 milligrams probably, prednisone, and then go down quite rapidly. And I tell the patient, no, we need to get this off soon because you will feel better, but this is not the best treatment for you now.
Thank you, Professor Sami. We'll close the session. Thank you.
Thanks a lot.
Next, we have a case-based discussion by Dr. Soundarya and Dr. Vignesh. I call upon the chairpersons and the discussants of the particular cases, Dr. R. Purkodi and Dr. Anupama Kumar. I request Dr. Soundarya to present her first case. She is a consultant from Myote Hospital. I hand over the session to the chairpersons.
Respected seniors and beloved friends, good morning all. Beginning with a thanking note to the organizing committee and the scientific committee and my professors for giving me the opportunity. And this case is about, it is not everything only ankylosing spondylitis, whatever we see with stiff spine. So this is a 39-year-old male who walked inside my OPD with a typical posture of an established ankylosing spondylitis with a stooped neck, and he is not even able to walk because of the stiff spine. And apart from this complaint he had for the past 1.5 years with severe symptoms in the recent days, and apart from this, he had whitish skin lesions all over the body. And he had consulted in several places and diagnosed to have ankylosing spondylitis. He was managed with low-dose steroids, NSAIDs, and sulfasalazine elsewhere. And because of the non-response, he was advised biologicals outside. So as a routine, what every patients do, because of advising biologicals, they came to me seeking second opinion. And his mother, she gave history of darkening of urine when he was in his childhood. She had noticed in his nappies. And his younger sibling also has similar complaints. He has low back pain with HLA-B27 positivity. This was just a note given by him, by the patient itself, but I hadn't seen his brother. So clinically, on seeing him, he had a scleral hyperpigmentation, and apart from that, he had vitiligo lesions all over the body, and his cervical spine movements and lumbar spine movements were severely restricted. His investigations are everything normal, including the acute phase reactants, but the HLA-B27 he did was positive by polymerase chain reaction. And this is his X-ray lumbosacral spine AP view as well as the lateral view. In the AP view, we can see the bony bridges connecting the several vertebrae, and in the lateral view, we can also see the intervertebral disc calcification. And he had an MRI also done outside where the sacroiliac joints were normal. Here in X-ray also you can see the sacroiliac joints are relatively spared, and this was again confirmed by the MRI, it was normal. And the spine sequences. In the spine sequences we can see still hyperintensities typically located in the D11 vertebra. The corner lesions, as well as in the T1 images we can see as hypointensities. And because of the intervertebral disc calcification and the significant past history that his mother gave, I did urine for homogenesic acid, which was positive. So it is one side, it is so clear that he is a case of ochronosis more than ankylosing spondylitis. But the things which are against ochronosis that not against ochronosis, but apart from ochronosis symptoms, he had other symptoms like an inflammatory back pain with early morning stiffness persisting for around 2 hours. Though the sacroiliac joints are spared, according to the ESA's classification criteria, we cannot include him as axial spondyloarthritis. But in his spine sequences, we can see the inflammatory lesions, especially in the corner, anterior-inferior corner, which even a single lesion, with a single lesion, we can even say that he can have the axial spondyloarthritis. And another supportive feature is the HLA-B27 positivity. So the final diagnosis is the coexistence of ochronosis and ankylosing spondylitis. On seeing the medical reports, I can see many reports previously, starting from 2007, they had reported the coexistence of ochronosis and ankylosing spondylitis. Thank you.
Thank you, Dr. Saudria. This case shows definitely this patient has ochronosis. He has the the classical triad of dark urine, scleral pigmentation, and intervertebral disc calcification. So there is no doubt that he has ochronosis. The classical feature in radiological feature in ochronosis is the intervertebral disc calcification. Because this can occur even in other conditions like ankylosing spondylitis also. But in all these conditions, the other conditions could be like in acromegaly, hemochromatosis, CPPD, or other things like even post-traumatic conditions, or even in normal individuals. 6% of normal individuals can have disc calcification as a part of degenerative joint disease. But in all these conditions, the sacroiliac joints are spared. In ochronosis, it's usually the nucleus pulposus that gets affected first. So there is vacuum phenomena and the central disc calcification occurs. Again, in hemochromatosis, where you get, it's the annulus fibrosis that gets calcified first. But in ankylosing spondylitis, we do get intervertebral disc calcification, but there should be evidence of sacroiliitis. And in this patient, initially you showed in the x-rays that he had osteophytes. There are no syndesmophytes. MRI picture shows some hyperintense lesions, which may be suggestive of an early enthesitis at the bone marrow or the vertebral tips. But again, his ESR, CRP, all that is normal. So I think at the moment, he has mainly an ochronotic arthropathy. And he has not responded to the NSAIDs and disease-modifying drugs which were used for him in the previous thing. On ankylosing spondylitis, there should be a dramatic response to NSAIDs.
Yes, ma'am, but previously he was on a single NSAID, but I changed the NSAID that I can observe response, that he says without that drug he can't be, he is not able to do the further work at all.
So only thing is that he has a positive HLA-B27. We should follow him up for developing other features like sacroiliitis, like Dr. Vinod that's spoken about non-radiological axial spar. That is also a possibility. So we have to follow, but he has been having this for over 1.5 years and he has not yet developed sacroiliitis. So I think mainly he has an ochronotic spondylitis and he has to be followed up for ankylosing spondylitis because he is HLA-B27 positive. As you said, there have been a study where they have taken about 15 patients with ochronotic arthropathy, spondylitis, where they are all HLA-B27 negative. And in them, only 6 patients had evidence of degenerative changes. And about 1 patient had even a positive rheumatoid factor, anti-CCP, and erosive changes on the X-ray. 2 were positive for ANA, and 2 patients had an inflammatory back pain and enthesitis and evidence of sacroiliitis. So 2 diseases can coexist. Nothing prevents them from developing. Even I have a patient with ankylosing spondylitis whose first-degree cousin has got ochronosis. So nothing prevents a person, but as of now, I think he has only a ochronotic arthropathy. Thank you.
Thank you.
Thank you, ma'am. Now I call upon Dr. Vignesh for a second presentation.
How do I start? Good morning, one and all. So at this juncture, I would like to thank the organizing and the scientific committee for giving me this opportunity in this nice occasion. So today we are going to see a patient with an interesting complaint of dysphagia, and let us see how the patient's history and findings evolve. So this patient is a 63-year-old female. She's a known diabetic for the past 8 years with a history of coronary artery disease, and she's in the postmenopausal state. She was admitted in the hepatology department with fever, transaminitis, and dysphagia. So the baseline workup for fever was negative. Upper GI endoscopy just revealed an erosive gastritis in the antrum with RAC negative, and barium swallow was just suggestive of a grade 1 esophageal dysmotility. So in view of polyarthritis, a rheumatology consult was taken up. So on elaborating into the history, the patient had fever for 3 months, dysphagia to both solids and liquids, with difficulty in getting up from sitting position for the past 2 months. Over the past 1 month, the history of proximal weakness has been worsening more, and she felt difficult even getting up from the bed and rolling over the bed. And she has been having complaints of polyarthritis for the past 1 month, and with history suggestive of Raynaud's phenomenon. In addition, she has been having a dry cough with dyspnea on exertion, MMRC grade 3, for the past 1 month. On examination, she was pale, and there was a bilateral pitting pedal edema. She had persistent Raynaud's phenomenon. There was no lymphadenopathy. She was not ecteric. She had some facial puffiness with a violaceous hue in the upper eyelids, which was edematous even. It was not a classical heliotrope anyway. And she had some hyperpigmented skin lesions over the elbow. When enquired, she said that was been a recent onset skin lesion, though there was no history of erythematous changes in the beginning. In addition, she also had irregular thickening and furrowing of the radial aspect of the index, middle, and the ring fingers, suggestive of a mechanic's hand. The vitals were stable, and respiratory system examination revealed infrascapular crackles with bilateral wrist, MCP, PIP, knee, and ankle arthritis. In view of arthritis, muscle power in the extremities were not being able to assess properly, but it was definitely more than 3/5. But the neck power was only 3/5, and she had truncal weakness. So on investigations, her HB was 10, acute phase reactants were elevated, renal function was normal, but the liver enzymes was OT more than PT, suggestive of some myositis component. Urine routine revealed 1+ proteinuria with a PCR of 0.8. Being a diabetic, her HbA1c was 8. ECG and echo features showed features of an old inferior wall MI, and she had only in addition a left bundle branch block. Her muscle enzymes were elevated, viral markers were non-reactive. Calcium, phosphorus, vitamin D, parathermone levels, and thyroid function test was normal. NCS was normal, and EMG showed myopathic pattern. It was done 2 weeks later once the arthritis improved. Her rheumatoid factor was positive, but it was only borderline. An ANA by indirect immunofluorescence showed a speckled cytoplasmic pattern, which is peculiar for a JO1 pattern, and that was confirmed by an LIA, which again showed JO1 3+ and Rho52 2+. Her radiography showed some bilateral heterogeneous opacities on the lower zones. The barium swallow was unremarkable. And this was the CT picture. So as you can see in the CT picture, in addition to the reticular changes, there is also patchy consolidation noted in the bilateral lower lobes and subtle ground glass opacities in the upper lobe and the left lingula. So there were some mediastinal lymph nodes, but they were just subcentimetric, and this was reported as an NSIP organizing pneumonia overlap pattern. So we have an overlap pattern of ILD in an overlap syndrome. So we screened her for malignancy. The basic workup was fine, pap smear, ultrasound, mammogram, and CT chest. But when we screened her thyroid, screening for some thyroid malignancies, we found a well-defined nodule in the region of parathyroid, which was taking vascularity with definite vascularity, suggestive of a parathyroid adenoma. But her parathermone levels, calcium and phosphorus levels were normal. So we got an endocrine consult, and they said we can just follow up the patient if at all they develop any new symptoms. So the final diagnosis goes this way, with an anti-JO1 syndrome having all components of it. Something peculiar here is this patient had an organizing pneumonia overlapping with an SIP, along with a non-functional parathyroid adenoma. So she was treated with physiotherapy, photoprotective and cold protective measures. She was adequately vaccinated for pneumococcal and influenza. Her latent TB screening was negative, so we didn't proceed with any treatment in that way. She was pulsed with pentylprednisolone followed by oral prednisolone. Her Raynaud's were taken care with sildenafil and bosentan, and we have been giving her pulse IV cyclophosphamide monthly, in addition with management of coronary artery disease and hyperglycemia. So one important thing we get to notice and practice is this patient suddenly once in a night developed retrosternal discomfort. The ECG change does not show anything apart from the 2,3 AVF inferior wall changes and LBBB. Her TROP-T and CPK was positive, which we expect in a myositis patient, but TROP-I was negative, and she was just managed with anti-reflex measures, and she improved. So follow-up after 3 months, there is no fever, the dysphagia and reflex symptoms have improved, cough has reduced, dyspnea scale has gone down to 2, and Raynaud's is under control, and you could see the Raynaud's phenomenon and the mechanic's hand vanishing after 3 months. There is no arthritis, and the muscle power has improved, and CPK and LDH is getting back to normal. So when we screened an ultrasound the 3rd month, there was no interval changes, and even the bone mineral profile was fine. So my questions to the podium here is mechanic's hand a cutaneous marker of disease activity in anti-JO1 syndrome? How common is this overlap of organizing pneumonia with NSIP? And was cyclophosphamide the right choice in this patient? The recommended screening protocol for malignancy for a patient with JO1 syndrome, and how to track on with this non-functional parathyroid adenoma. Thank you.
Thank you very much for this interesting case presentation. The case is open for discussion, but I think the last question which you asked about parathyroid adenoma, I think it could be a coincidental feature, but as we know, incidences of malignancies are more in connective tissue diseases like this, especially poly and dermatomyositis, we could check it by having a continuous eye on this. The rest of the questions are open for discussion.
As far as malignancy protocols are considered, actually anti-Jo1 is almost a negative predictor of malignancy. Of course, MI2 is a negative predictor. Even Jo1 is not most of the times associated with malignancy. When in association with ILD, the malignancy incidence also reduces. Obviously, we have cases with ILD and malignancy, but again, much less.
We had to screen her because of her age, ma'am.
Yeah, age as such, but isolated dermatomyositis without myositis specific antibody, definitely yes. But with the MSA, maybe we can go ahead with a less of a screening protocol for malignancy. That's it.
Sir, actually, and we were actually planning for a PET CT for this patient, but her sugars during the hospital stay never got under control. Though her baseline was okay, HbA1c was 8, we were never able to get the sugars under control. It was always moving around 180 and 200. And being an elderly patient, we don't want to get her more into a strict control. And the nuclear medicine specialists were all keen on bringing down the sugars to 100 and 110. So it was not possible at that time to get it done. Sir, the case reports of NSIP organizing pneumonia are very, very few, sir. In majority of the cases, they have tried cyclophosphamide, and in some refractory cases, they have tried rituximab. I have not found any evidence of mycophenolate mofetil used primarily for this condition, sir.
Regarding the questions you had written here, mechanic sand is definitely a clinical clue for the diagnosis. I'm not sure. I've not read the recent literature. I don't think it is a marker for activity. We have seen a lot of patients who are improving very well clinically, myositis, lungs, but mechanic sand remains. So it doesn't look like a marker of disease activity. I feel that NSIP, OP overlap syndrome is an evolving interstitial lung disease. I don't know how the radiologist has chosen to name it. Is that organizing pneumonia comes in here. I think it's an evolving picture. We don't need to give too much of importance to it. I think you have chosen cyclophosphamide based on interstitial lung disease. Looks like a good choice. You need to maintain with maybe mycophenolate or azathioprine.
I'm just one comment and one statement. The comment is actually because she is elderly and she had a coronary artery disease before, I'd be very careful with the steroids because, during treatment for her ILD and antisynthetase, she might develop a cardiac event and that might be her terminal event. So we'll be very careful about that. Second is actually just regarding the PET scan. Now there is enough evidence you screen by conventional methods of different screening and PET scan, both are the same. Sometimes we tend to think that PET is better than scan, but there is now enough evidence to say either way you do it, the evidence is, the results are the same.
Thank you. Now we close the session. Proceed on with the next session on interstitial lung disease. I request the speakers to stick on to their time, we are already running short by 20 minutes. And we also have an app here. So people who want to ask questions, you can post your questions on the app so that the questions also can be selected from the same. So I request the chairpersons for the next talk, Dr. G. Narasimulu, to chair and Dr. Binoy Paul to chair the session, please. I request the speaker, Dr. Chandrasekhara, to take the stage.
Pointer, sir.
Okay. Only pointer, you don't have the...
On next slide.
Clear me? Hello. Good morning. Today, one of the important topics in rheumatology about ILD. How to treat ILD. We come across more frequently secondary ILD in rheumatology practice compared to pulmonologist. And one of the reason for mortality in various disorders like scleroderma and RA. About my friend Dr. Chandrasekhara, I did not introduce. He is from Bangalore, senior most rheumatologist from 97, 98 practice in Bangalore. After the DM in Sanjay Gandhi, here people who visited Bangalore must visit Chandray Rheumatology Center. It looks like an institute. Recently I went and have a good sweet hospitality. Dr. Chandrasekhara, kindly educate us what is the latest in ILD and make us more effective improving the patient care. Thank you.
Thank you, Chairperson, for a nice introduction. And at the outset, I thank the organizers and the scientific committee to thinking me I am deemed fit to answer some of the questions which we are still pondering upon, that when, what and how to treat interstitial lung disease, the rheumatologist's perspective. I have just put a small bracket, a immunologist perspective too, because most of the talk I will be focusing on the areas where we look the interstitial lung disease from the immune perspective, because that's how we are now trying to look at the diseases of autoimmune disease perspectives. See, the main role a rheumatologist plays when it comes to interstitial lung disease, one is the diagnosis, the other component of it is the treatment. The interstitial lung disease, we face it in two ways. One is patient may have interstitial lung disease alone or perceived to be having interstitial lung disease alone. What I mean is patient may have subtle symptoms, some of the autoantibodies which is not yet been explored, perceived to be have interstitial lung disease. The other way around is you may have a patient with connective tissue disease where you need to think about a possibility of an interstitial lung disease in them. So before getting into answering the questions, there are a few points which I would like the audience to be clear, that interstitial lung disease is not a single entity. It encompasses more than 200 different etiological causes and possibility of a 200 and or other different diagnoses. And we need to be sure it's an inflammatory disease, and it occurs as an immune aberration. It could be an immune aberration against the self protein, what we otherwise call autoimmune, or an hypersensitivity to an external antigen. Ultimately, what it leads to is to the fibrosis. So with this concept in mind, the treatment and prognosis depends on the cause, the pattern, and various other factors which are there along with interstitial lung disease. Why should I really worry about this, and what really makes interstitial lung disease different? To give the best example for us to understand, there are two broad spectrum diseases which I would like to compare. I mean, this is a little crowded slide, and this is how the crowding of immune response occurs. And the one on the left side is of the interstitial, primary interstitial fibrosis. The other one is the interstitial lung disease associated with systemic sclerosis. One at the bottom is a normal lung. What we could really see the difference is, if you could see in systemic sclerosis, there is a crowding of lot of immune active cells or immune competent cells like macrophages, T cells, B cells, etc., which are sparsely seen in interstitial lung disease, primary or interstitial pulmonary fibrosis, IPF, what we otherwise call. So what it means to us is, when we are trying to treat the condition, if there is more of immune reactions, more of immune competent cells, more of inflammatory cells present, there is a reason for us to intervene these group of patients with immunosuppressants, anti-inflammatory drugs, etc., which may not be the reason when it happens to be the pulmonary fibrosis, where the amount of inflammatory response is less and it's predominantly driven by the fibrosis. To look at in little more dispersed pattern, you could see that the one which are in the dotted lines are the predominant cells which are present in IPF. That is, one is the alveolar endothelial cells as well as the mast cells, whereas in the case of interstitial lung disease associated with connective tissue disease, you have more of the players by the immune inflammatory cells. So this being the fundamental, when we need to treat or diagnose, the first initial step should be is to figure out the pathology. We need to find out or identify what exactly is the pathogenic process or immune pathogenic process that's happening with reference to or with relevance to the patient. And we are talking about two wide spectrum disease. What we talk about is a primary interstitial fibrosis, where the choice of treatment are less and where we almost take it inevitable that the progress of the disease is not easily can be restricted as much you can do with reference to the other reasons or other causes of interstitial lung disease. That's why there is an algorithm that's been developed in 2017 publication of Pulmonary American Thoracic Society. The basic intention is to differentiate the IPF from the non-IPF, because the reason is the way you need to treat IPF is entirely different from the non-IPF group of patients. So if you have a suspicion of ILD, the step one is confirm with the methods that yes, it's interstitial lung disease. Then HRCT shows a typical UIP pattern, and clinical history suggests that there is no other reason to suspect other causes for interstitial lung disease. Treat it as definite IPF. If you are still not sure that it is only IPF, because of either the HRCT pattern, clinical pattern, or any of them are still suggesting that it could be just not IPF, explore further, including bronchoscopy, lung biopsy, and any other means to prove that it is not just IPF, it's another associated interstitial lung disease. Basically, the intention is the treatment choice is going to be widely different, because if it happens to be the interstitial pulmonary fibrosis, the treatment choice are different compared to a patient of interstitial lung disease of inflammatory cause. This particular diagram literally consolidates the entire spectrum of the treatment. If it is organizing pneumonia or NSIP, here again, if it is predominantly less of fibrosis, more of pneumonitic and inflammation, aggressive anti-inflammatory or immunosuppressive drug or immunomodulatory drug is going to help the patients. As the fibrosis component increases, if you can see that NSIP predominantly cellular, NSIP predominantly fibrotic, and in the end of the spectrum, more of a fibrotic disease, the chance of treatment with inflammation or anti-inflammatory or immunosuppressive drugs are going to be less of a use, and it is predominantly to be taken over by the anti-fibrotic drugs. Though there are few drugs which have come to be used in the line of anti-fibrotic drugs, none of them are as efficient as we look at it, but there are trials and research that's going on in exploring more of anti-fibrotic drugs. This makes us the point clear that which are the set of patients where you can go aggressively with immunosuppressive and immunomodulator, where you should start thinking less about the immunomodulators and immunosuppressants, especially when the fibrosis or the fibrosing features dominate the interstitial lung disease. So to in addition, that if you have a patient with a connective tissue disease, having many of these autoantibodies, there is always a clinical possibility of these patients developing interstitial lung disease. The other way around, if a patient with interstitial lung disease need to be explored about the possible association of any of these autoantibodies. In the presence of these autoantibodies, you consider it as an interstitial lung disease with a connective tissue disease. I think next speaker is going to speak in detail about this particular topic. And of course, the question when this is where we need to, if there is a positivity of any of these autoantibodies, we need to step in as a rheumatologist and take treatment, take charge of the treatment of these set of patients with immunosuppressants and immunomodulators. If you read the literature previously, 10 years back or 12, 13 years back, the always question that used to be raised is, should I really aggressively treat an interstitial lung disease patient with immunosuppressants, or should we not treat these group of patients? The question predominantly remained was to treat or not to treat. There were enough literature to say that using cyclophosphamide, using azathioprine, even in the presence of, in an interstitial lung disease with connective tissue disease, mortality and morbidity do not significantly change. On contrast, there is a possibility of increased infections, and death secondary to infections are higher, vis-a-vis compared to the group of patients where we don't intervene with that. But several studies have now clearly shown that if you identify early, and if you treat the group of patients with connective tissue disease and interstitial lung disease, the outcome is much more better. But we still have a problem with reference to primary interstitial pulmonary fibrosis, where fibrosis dominates. In this set of patients, using immunosuppressants are not going to significantly change the outcome of these patients. Again, there are few points which we need to consider. If you figure out early in the patients of interstitial pulmonary fibrosis, in the early course of the disease, because ultimately the trigger of fibrotic process, trigger of the fibrosis which sets in even in IPF could be or as a possibility of an altered or a triggered immune responses. There is a possibility if we treat early in the course of the disease of even in IPF, probably outcome could be better, but the question remains is how early, how we should screen these patients. As we know, most of these IPFs are in elderly, above 50, 55. Chance of them having breathlessness and symptoms related to IPF are less, and they usually present late in the course of the disease because of restricted mobility, restricted exertional activity in them. So that being the case, even picking up a possible IPF in the early course of the disease may be little difficult, but one need to consider that as a possibility. So how to treat? The algorithm is pretty simple. Once you suspect ILD, look for HRCT, try to type the type pattern of the interstitial lung disease, and then once you are sure that there are some pharmacological intervention which is possible, you can use either antifibrotic if it is IPF, or you can use immunosuppressant and immunomodulators. In addition, you need to also use non-pharmacological intervention like oxygen therapy, intermittent oxygen therapy, night oxygen therapies, as well as the pulmonary rehabilitation. Also simultaneously look and treat pulmonary hypertension and overall well-being of the patients. So in a subsequent follow-up, every 3 to 6 months, have a follow-up, look at the improvement that's happening. If no significant improvement is happening, there is a choice to choose between the drugs. You can move from one immunosuppressant to another immunosuppressant. For example, if there is no adequate response to mycophenolate mofetil, you can take a chance with either the cyclophosphamide or rituximab. And of late, the other drugs are also being used in managing as an immunomodulator or immunosuppressants with the patients other than primary IPF, where one can get adequate good results, at least in stabilizing the disease, though not in improving the overall lung functions and mortality and morbidity. So when it comes to the treatment, as I said, I just run through some of the slides, wherein IPF, interstitial pulmonary fibrosis, just to recapitulate, we don't have much of the treatment. Usually we use respiratory rehab with antifibrotic drugs. In sarcoidosis with interstitial lung disease, one can use steroid immunomodulator like methotrexate, the MMF, azathioprine, and even so there are some clinical trials of using anti-TNF which can be of some help. And again, as I said, based on the pattern that like you have NSIP, one can use mycophenolate and corticosteroids, and especially organizing pneumonias, one can use high dose of steroids. And hypersensitive pneumonitis, one need to figure out the trigger factor, the drug or whatever the responsible factor, eliminate them. In addition, one can use corticosteroid with a possible utilization of other medications. So in conclusion, one is to identify a treatable cause of ILD, if any, and which, of course, we need to remember that even the ILD can occur as an exposure to drug and environmental pollutions and pollutants like the work, especially in the mining and other industrial areas. One can figure out the trigger factor and eliminate it where it is possible. In other conditions like connective tissue disease, we have the immunomodulator. So one need to look seriously for connective tissue disease. So the patients with connective tissue disease and ILD with a connective tissue disease, that's where a rheumatologist step in to figure out and identify the diagnosis. What to treat? As I said, identify the cause. I think the last few slides are clearly suggested how to intervene and how much to intervene. And how to treat is the basic fundamental of any of these autoimmune disease is to use immune modulators and immunosuppressive more effectively and as effectively as possible to reduce and bring down the inflammatory trigger or inflammatory process that's happening so that you can reduce the extent of the fibrosis and damage that's happening to the lungs. But at the same time, as a rheumatologist, more often we focus on immunosuppressants, forgetting that patient will have a pulmonary hypertension and other problem related to pulmonary hypertension. Do not forget simultaneously to treat and handle the pulmonary hypertension, where you can take the help of, if required, a cardiovascular colleague, and to treat the pulmonary hypertension simultaneously. So the major problems still persist. This is the sketch of the first sketch which I have put it in 2017. While we are trying to build on developing an in silico model for predicting which is the best immunosuppressant or which is the best immunomodulators one can use and work with connective tissue disease. And we are just trying to work on the multiple levels to develop these in silico models, wherein using genetic factor, the phenotypic pattern, the biomarkers, and the clinical signs and symptoms to finally come out with an outcome of what to treat. We are still need to address this particular question. It is as hazy as these sketches are. Hopefully, over a period of time, using some of the biomarkers which are under the research process should help us and guide us to pick up the best immunosuppressant or best immunomodulators with which we can intervene and treat this group of patients. Thank you very much.
Thank you, Dr. Chandrasekhara, for the excellent talk, and hope we are not confused with the last slide. I have a question. Do you still believe that there is an entity called lung-dominant connective tissue disease?
Sir?
Lung-dominant connective tissue disease.
Yeah, we do. We do have, I think, quite a good number of patients. We do find out, we do see first clinical manifestations to be the lung, and it's only the pulmonary manifestation which is there. And they have, for a reason which we really can't explain, extreme localization of the entire inflammation in the lungs. And for example, you can have a rheumatoid anti-CCP positive, predominantly presenting for the first time as interstitial lung disease.
How can we help those patients by starting treatment much early?
No, especially as I said, if it is not IPF, use of immunosuppressants is the best way to treat these patients. Especially if you pick these patients when the lung involvement is less than 20%, the outcome is good.
What is your comment on pirfenidone? Pirfenidone.
I think I gave my
Connective tissue disease, in the setting, not in the setting of IPF.
No, in the connective tissue disease, as I said, see there is a midpoint where we can use both immunosuppressants and antifibrotic. If you have seen that in the third slide, there was a slider which moves towards the fibrotic, that is especially NSIP with fibrosis dominance, where inflammation is less and fibrotic processes are dominant. Probably in that place, Pirfenidone may be useful, but in the conditions which are much earlier, the Pirfenidone may not have much role to play.
Any questions from the audience? Yeah, Rajmanikam.
Chandrasekhar, excellent talk. Now, going to what Dr. Binoy Paul said, using an antifibrotic from the pathogenesis described in connective tissue disease and ILD, there does not appear to be any role at all. You'd agree with that?
I could get you.
Yeah, because although IPF may have a cellular component initially to start with and then progress on to the fibrotic state, the pathogenesis is completely different. So the take-home message here is Pirfenidone is not effective in connective tissue disease. Correct?
No, I don't fully endorse that. What I was trying to say is, in the patients who have early pneumonitis, the fibrosis might have not taken over in a much higher way. So if that's a case, in that scenario, using immunosuppressant is enough, because quite a good number of immunosuppressants, especially like cyclophosphamide, mycophenolate, do have an influence on fibroblast and fibroblast physiology. So when it comes to a predominance or a dominance of fibroblastic activities, where say for example the disease has progressed for 4 or 5 years, where the fibrosis dominates, probably there could be a role of these antifibrotic drug in this set of patients.
When coming to the fibrotic assessment of that fibrotic element, I think we've got a HRCT talk coming up next, and I think we'll discuss it then. On the basis of the choice of immunosuppressive drugs as we know now is based from all the literature evidence from what we have from systemic sclerosis onwards. And cyclophosphamide seems to have been the main, but from your current reading, when it comes to choice, do you have a particular choice between mycophenolate, azathioprine?
The current choice is on an arbitrary basis. That's what we are trying to figure it out. For example, both mycophenolate, cyclophosphamide, and rituximab are shown to be equally effective in the conditions of ILD. But if you see that in each of these subgroup, that's cyclophosphamide, 40 to 60% respond. In rituximab, 40 to 60% respond. But and also it is our clinical experience, you give cyclophosphamide, not responding, use rituximab, the patient respond. So the choice comes is that because of different immunopathological processes, probably the choice of these immunomodulator could have been different. But that's where the last slide which I presented, that's where the work required.
Thank you, Chandrasekhar. Point is well taken. Before concluding, last question I'll put for sake of audience. How do you recognize a preclinical ILD and do you treat it?
Preclinical ILD?
ILD, do you treat it? How do you recognize it? And do you treat it?
There's a early onset, if I detect a patient with an early ILD, I will treat him as he has ILD.
Not early ILD, preclinical ILD. The entity has come.
Preclinical ILD, I'm not very sure whether we still use that term, because what we look at is, if the patient has an autoantibody with an inclination to develop an interstitial lung disease, it's best to be managed with a good amount of aggression in your picking of the choice. For example, say a patient has SCL70 and has a very limited clinical features of interstitial lung disease at this point of time. Keep in view when you are treating these patients, that patient is more likely to develop an interstitial lung disease. Regular follow-up, you have a follow-up of the preliminary evaluation, and use the drugs which are little more higher than what you would have otherwise conventionally used.
Yeah, thank you for excellent coverage. A new entity of preclinical ILD data getting accumulated a lot. Last year, Geneva Arthritis Rheumatology, there are follow-up nearly 560 cases of preclinical ILD. And I think they worth reading that article. Is some people have treated it. We CT recognizes ILD with activity and action score, but patient is asymptomatic. That entity they have described as preclinical ILD. There is a controversy whether to treat or not. Thank you, Dr. Chandrasekhar, for giving excellent talk on ILD. And I give mic
back
Thank
to
you,
organizers.
chairpersons, and thank you, speaker. And for the next session on HRCT chest interpretation of ILD for rheumatologists, Dr. V. Rajamani and Dr. John Matthews are the chairpersons.